Welcome to the LMD Podiatry Podcast. Trust us to get back on your feet. Here's your host, Dr. Lauren DeBaccaroff.
Hey everyone, Dr. Lauren DeBaccaroff here with the LMD Podiatry Podcast. We have a special guest today, Dr. Wadehra. He is a colleague of mine, and we do a lot of the same stuff. And we're gonna kind of run through all that. How you doing, Doc?
Good. Thanks for having me on this. This is great.
All right. So tell us about yourself a little bit so everybody knows who you are, where you're from.
Yeah. I practice in the suburbs of Detroit, Michigan. I'm in a city called Birmingham, Michigan. Started a kind of like a hybrid concierge practice a couple of years ago. Really specializing in minimally invasive foot surgery, but also regenerative medicine, which I know you and I are going to talk about quite a bit here shortly.
Very exciting. So why don't we just I like to always open with what is regenerative medicine and why is it different than the conservative approach that everybody's been used to for the past many decades.
Mm-hmm.
So basically, regenerative medicine is, I like to call it like harnessing the body's ability to heal itself. Like a lot of things become chronic, like plantar fasciitis becomes chronic sometimes, Achilles tendonitis. People have chronic sprains and things like that. And then there is not much in the world of traditional medicine that gets those areas to heal. And that's when regenerative medicine comes in. We use things that have special qualities and properties that kind of wakes up those cells on a cellular level to heal. What do you use in your office, Dr. Wadehra?
Yeah, I think you put it really well. I like the the way you describe regenerative medicine. That's how I talk to my patients about it too. You know, the body is very smart. If you give the body what it needs, it truly can heal itself. But to answer your question, we utilize a variety of different methodologies. One is shockwave therapy or EPAD therapy. We do a lot of laser therapy in the office too. But my favorite really is utilizing different biological injections, not steroid, but biological injections.
Right. Because steroid, it won't actually heal the area. So let's say you take the plantar fascia. It's a very tight band on the bottom of your foot, and fascia doesn't stretch. And then what the steroid does, it actually just removes some of the inflammation, and it doesn't actually heal that structure at all. In some cases, it can help. Like it'll take away a lot of that inflammation, allowing kind of like for the environment, a good environment for the foot to heal, but it doesn't actually repair anything. And then when it comes to other things, or if you inject the steroid around tendon, it can be very harmful. It could actually weaken the tendon, weaken the ligament, and cause other damage, and puts you at high risk for tears and ruptures down the line. So that's what we kind of want to avoid. But unfortunately, traditional medicine goes there a lot of times. So I think you and I use the same biologic. Use the DPMX injection.
Yeah, I use a variety of different injections now. I do utilize them from time to time, but I've been kind of dabbling with different types of Wharton's jelly products, along with exosomes and actually products that even contain live cells. But yeah, again, to answer your question, DPMX is definitely one of those that I use quite often.
Well, what are the other ones that you use? Because
I've been utilizing
basically like a Wharton's jelly, and the way I explain it to patients, I just say it's the thickest part of the umbilical cord that's the most rich in native or stem cells, and that they have all these properties that are pro-inflammatory, and they basically tell the body to heal itself on a cellular level.
Yeah, no, that's exactly the way to the way that I describe it to patients as well. It's almost like, I'll use the analogy sometimes, and I'll come back to cortisone for just a second. Cortisone, like you described it, is like a Band-Aid approach. It turns the pain off for a little bit, but we haven't done anything to actually heal the issue at hand, the root cause. So what I'll tell patients is, when you inject something like Wharton's jelly, it has all the ingredients that we need to truly repair the problem at hand. So an analogy I'll use sometimes is, imagine you have a hole in the drywall. You're going to go to Home Depot or Lowe's, you're going to buy a drywall patch kit that has all the ingredients it needs to fill that hole. That's exactly what Wharton's jelly is giving the body the ingredients it needs to patch the hole, patch the fracture, whatever it is, truly giving the ingredients it needs versus just putting a Band-Aid on it and then hoping something happens. But as you know, most often when you do that to patients, they come right back through the door saying, "Doc, it worked for a little bit, but now I'm even in more pain."
Yeah, I see that all the time. So I personally like to use the Wharton's jelly in conjunction with laser.
Mm-hmm.
And I actually have higher success rates with it because most patients don't listen. Like, not in a bad way, but like I had this guy, I gave him the Wharton's jelly injection. He felt, for his fascia, he felt so good. He started like climbing the canyon, the Grand Canyon. I don't know what he was hiking over there. And then he like uses ladders at work. And I'm like, and then I actually do a lot of diagnostic imaging in my office, and I have an ultrasound, and I took a look at his ultrasound to see why he was in so much pain. It was amazing. In 3 weeks, the fascia actually shrunk in size. The normal width of the fascia is about, his was bad. His was like 7 millimeters or more, and then it was already down to like 5.5 millimeters, which is amazing. But you saw all this inflammation around it. It's like, great, I gave you this medicine to get your body to heal itself, and it's doing a good job, but you're aggravating it. So once I like forced him to kind of go in a boot, and I had him do 6 I used the MLS laser. We did 6 sessions at the MLS. I never saw him again. He was fixed. He gave me a testimonial and everything. And ever since that, I don't let patients get the injection without it, because I love the MLS laser. It tells your cells the mitochondria in your cells to make more energy, and it takes away a lot of the inflammation. And I actually have found a lot of studies that it actually enhances the ability of the Wharton's jelly injection and all those type of biologic injections to work better. So do you use that in conjunction, or you do it separately?
No, I very routinely will package it with Wharton's jelly with a combination of MLS laser and shockwave therapy. I find the two, especially with heel pain, I find that the MLS plus shockwave actually complement each other very well. And then you throw the injection on top of it, you create a really nice sound environment for some really good healing.
So in what cases do you do the shockwave for? Or you just use all 3 modalities for?
It really primarily my soft tissue type of tendinopathies, so Achilles tendinosis or plantar fasciosis will utilize the combination of the two. Very rarely am I doing just shockwave alone or just laser alone. Of course, neuropathy patients, those are probably just going to get laser alone. Or post-surgical patients, we do lots of MLS. But again, for these chronic conditions that patients are dealing with, again, soft tissue wise, I like the combination of the two, the shockwave plus the MLS laser.
Well, what is I know you use the EPAT, right?
Yeah,
I don't have that machine. Okay. So how is it different than the extracorporeal shockwave?
It's under the same family. Essentially, there's no electromagnetic type of methodology behind it. It's basically high pressure sound waves that are being pushed into the patient without the use of any sort of electromagnetic, again, type of product. But the idea is the same. The idea is that we're stimulating, I call it exogenous inflammation, if you will. You're creating inflammation on purpose to jumpstart the body with the shockwave or EPAT therapy. And so we're bringing good blood flow to the area. We're breaking up scar tissue. We're bringing the body's own natural stem cells to the area. I find that if you pair it with MLS similar, it'll bring good blood flow to the area, but it'll then flush out all the bad cells, the histamine releases that we get, the bad, you mentioned mitochondria, right? We basically recycle the bad mitochondria, bring fresh mitochondria to the area, and the mitochondria releases ATP. So I found that the two together really create a really great environment. And then you hit them with some Wharton's jelly on top of all that.
So how do you separate them? You do the EPAT, you do the shockwave first, and then MLS, and then like how long do you like separate it between the like?
So it's a good question. I've been playing around with different type of protocols and talking to colleagues, but what I found that works really good in my hands, if you were to just, if you do like utilize these three types of modalities, let's just use plantar fasciitis or fasciosis for a second. I typically will start them with I'll start with EPAT first, and that same as soon as we finish the EPAT round, I'll hit them with MLS laser, and I'll do 2 to 3 of those, and then have them on the third visit.
In the same time that they're there?
Same time they're there.
Oh,
Same time they're there. And third visit, we'll have them come back, and we'll just do the injection that day. We won't do anything else. I'll wait 2 weeks, and then start the process back over again.
So you do the EPAT and the
MLS.
The MLS in the same setting,
Mhm.
and you do what, 3 in a row, each one a week apart?
Yeah, I'll do 2 to 3 first, and then 2 or 3 first, 2 to 3 weeks, and then back in for the injection. Wait 2 weeks, and then give them 3 more rounds of that.
I spoke to Dr. Spear. He's also one of our colleagues. He said that he does the EPAT 3 in a row, and then he does the Morton's jelly, and then he does another 3 EPATs, and he gets really good response from that.
Yeah. I've heard some people just do 3 rounds of EPAT and then Morton jelly and call it a day. So we don't really have any, quote unquote good protocols yet. It's all anecdotal.
Right, I know, because regenerative medicine, it's a brand new field. The whole point is like we said, just to get the body to heal itself.
Right.
So I'm a stickler for immobilizing the patient. Do you put them in a boot?
Yeah, I do. I recommend it. I mean, do patients listen to me? That's the other, that's the other half. Who knows?
They don't listen to me.
Right. So you just, I tell them this. I said, look, the boot is to do 2 things. It's number 1, to give that foot just a break from life so that we can truly allow it to just start healing. But it allows you to stay mobile. The second reason I like the boot is because, it keeps that injection pretty much where I want it to be versus spreading out. Now the foot's small structure, so would it actually spread out and they'll lose the area? I don't really think so, but I like the boot because it truly just gives them. It reminds them that they had something done recently too, so they should just take it easy. But again, like your patients, my patients sometimes don't listen to me. They want to get back to life. You can only educate, right?
Yeah. I mean, I think I always make the analogy. I tell patients all right, this is the problem with your foot. And then I tell them, if you sprained your wrist or dislocated your shoulder or something, you'd stop using it for a couple of weeks and you feel better. And then the problem with, us, our field, foot and ankle specialists, nobody stops using their foot. And then I just keep kind of reinforcing, how do you expect your body to heal itself if you keep using your foot all the time? Your foot, the pain is a signal. It's a blessing from your body. It's your body telling you, please stop using me. So you have to listen to your body. You can't just walk this off. And then, with the regenerative medicine, healing time is pretty much half of what most people expect. I do it a lot for sports medicine injuries. And I've had a really good, some people that have a really bad ankle sprain, whether it's the ATFL or the deltoid, I confirm it with the MRI and give them the injection, put them in a boot. And then I actually see, you could actually on the ultrasound see only 3 weeks later that everything is filling in. Whereas traditional immobilization for ankle sprains, maybe in 6 weeks it'll close. So
that's pretty cool. That's cool that you can see that on ultrasound. I agree with you on that acute injuries, it works really, really well. Are you utilizing Wharton jelly for post-surgical patients?
That I'm not there yet, because it's funny. Down here in Florida, patients don't want surgery. They don't want time off. They don't want a boot. They would rather live with their pain, or I don't know. It should. I mean, I know you do minimally invasive surgery in your office. I do